Great. Thank you, Charlie. It's been a real honor to be working with CED over, I think now almost the last 15 years or so. As Charlie said, I don't believe it's over yet either. I mean, we've been here before. I mean, healthcare reform, it almost seems to be living the life of, I think it's what, the cicada insect that comes back every 17 years. Seems like healthcare reform comes back every 15 years, and really been the case since the Truman administration, and we've been on the precipice of healthcare reform several times before. I think CED, seeing that the next cycle was coming, had the foresight back in 2005 to say there's about to come another bite at the healthcare reform apple, and let's see if we can get a little bit ahead of the curve. And convened back in 2005 under the leadership of Charlie and of Alan, a group of 12 trustees and a number of experts in the healthcare field to really take a look at that time at the U.S. healthcare system and try to understand, is there a way to optimize sort of the holy trinity of cost containment, or at least bending the cost curve, as Charlie said and President Obama had said, quality, and inclusiveness. After 2 years of study, we actually unveiled our findings here in San Francisco back in 2007. At the time we did that, the healthcare system, was in a, basically was not delivering. I mean, I think that was the basic conclusion. I mean, numbers that are very familiar to everybody in this room. As Charlie mentioned, our cost of healthcare delivery is anywhere from 50 to 60% higher than everybody else's. 16, now 17% of GDP versus 9 to 10% with no better results. Inclusiveness, certainly not a stellar mark for us. 15% of the people not part of the healthcare insurance system. And the numbers are all worse right now. If, all of us basically, I think in this room, most of us have business backgrounds. If you were looking at this situation and you were on the board of directors of a company where your cost structure was 50 to 60% higher of your competitors, you were not serving 15% of your customers, and your product was no better with this higher cost structure, you wouldn't tinker at the edges. You would probably look to fire the management team and radically change the business mission of the company. And I think that was the conclusion that we came to at CED. And in particular, we think that the core issue is employer-based health care, which, as we found, has actually been a somewhat politically inconvenient conclusion to come to, in that the basic drivers of employer-based health care, as structured in the United States, lead to the opposite. They do not lead to a competitive marketplace. They do not lead to continuous improvement. They do not lead to improvements in quality. They do not lead to inclusiveness. Basically, at this point, 60% approximately of employers offer employer-based health care, and that's been a declining number over years. Less than 60% of people are covered. Costs are continuing to increase faster than inflation. What we believe the core cause is lack of market mechanisms. I mean, you think of it as a market-based system, it's about as far away as you can get from a market-based system. 77% of employers offer just one health care plan. There is not choice at the consumer level, or as there is in just about every other industry, and competition at the consumer level. And CEDs came to the conclusion that we needed to evolve away fairly quickly from the employer-based healthcare system. This is not sustainable. This is leading to upward costs without improvement in quality, unlike just about every other part of our economy where competition has led to decreases in costs and improvements in quality. And our plan is really around a few basic tenets. One is competition at the consumer level, at the patient level, through exchanges. And exchanges where people can have a choice of plans very similar to what the federal government offers its employees and actually offers Congress. And what we're asking for is essentially no better system than what Congress has itself, where they have actually a large selection of plans, they compete against each other, it drives improvements in quality. Secondly is introduce cost consciousness into the system, sort of an alien concept right now in the insurance marketplace is by capping contributions, basically fixed contribution, and getting rid of deductibility above that amount. introduction of information technologies, and then fourth, a healthcare Fed, where they both provide minimum plans for people, basic requirements for minimum plans, plus fund research into cost, basically effectiveness comparisons, best practices, which can serve as the basis of national improvements and standards. We think these are some pretty simple concepts. Introducing competition, capping the exclusion, fixed contributions, basic standards that can lead to inclusiveness, lead to improvements in cost, lead to improvements in qualities. Alan has done a huge amount of work, I know he'll talk to you about this later, about why that is the case and why this type of system really could work. And as Charlie's mentioned, we don't think the game is over yet. We think Senator Wyden and Senator Bennett's bill is a good start, and we think that there's others that perhaps if they're looking at how do we actually pay for this, how do we actually provide the coverage that we want, how do we provide the quality improvements, that people are going to come to a conclusion fairly quickly that you need to go to a different system. So I think those are the basics of what CED is providing, and I think they're quite consistent with the thoughts that many of you might have here of how to produce marketplace improvements in the healthcare system. So I'd like to thank you for your attention here. I think we're going to have a very lively debate today about some of the ways that we can bring this forward over the next coming months. Thank you.